since you guys are in first year and second years, I want you guys to be attentive on one particular aspect that you should understand the basics now. We have planned actually a 2 year schedule for you so that in this year you pay attention to the basics. The advanced things will keep coming. We will teach you advanced things also. Even if you don't grasp them well, that is okay because they are going to come again. Let us understand what happens actually at the tissue level when there is injury. So there are two levels where injury actually demonstrate. One is at the tissue or cellular level, the other is at neuroendocrine level. So let's first discuss about tissue level. What happens is whenever there will be injury, there will be cell death will release something called as DAMs. These are death associated molecular patterns. They are not specific or one molecule. They are pattern of molecules or families of these molecules which exhibit a same what do you call quaternary structure of the protein. So it is actually not just one molecule but a collection of molecules. So what are these molecules? These are heat shock proteins, HMGB1 protein, 100 protein, and since all of them are protein derived, the one is fragments of nucleic acids. You need to understand one simple fact. Why ain't fragments of amino acid can be a part of DAMs? Because amino acids fragments will not exist in nature. Most commonly, injury happens because of heat or because of increased acidic environment which actually destroys the entire protein. So there is no protein left and hence the fragments of amino acids are not considered. Actually, they are not present only in a structure where there is damage to the cell. So that's why one of your question has this option fragments of amino acids will come to that. Understand first that these all molecules are considered as death associated molecular patterns. What do they actually bind with? Three areas. Now we know that when whatever will happen, it will come the moleculisments of the body or the innate immune system will come into the picture. They will interact with them since the closest to them is always endothelium and there will be platelets. So on neutrophil or what all innate molecules are there? Neutrophils, macrophages, and dendritic cells. On these cells, there exist what is called as toll-like receptors or knot-like receptors. So when this death-associated proteins or molecules bind to these toll-like receptors or knot-like receptors, they in turn produces a cascade where they forms what is called as inflammasomes. These inflammasome in turn goes to the nucleus and increases transcription of factors like interleukin 1, TNF alpha, interleukin 6. Interleukin 1 and TNF alpha are also called as pyrogens. So they causes fever, increases the body temperature. Interleukin 6 acts as acute phase reactant releasing molecule. So it will go to the liver and ask liver to produce more proteins that are called as acute phase reactants. These DAMs will also interact with the endothelial cells and causes endothelial damage, as a result of which the blood vessels will become leaky and there will be tissue edema. These DAMs will also go to platelets and will causes platelet dysfunction, and hence when these vessels are leaky, the platelet won't be there to plug it, and hence the leakiness continues and the tissue edema continues to develop. Since tissue edema continues to develop, what will happen is more and more injury happens to the cell and more DAMs are produced. So this is what is happening at the cellular level. What happens at a neuroendocrine level? Whenever there is an injury related neurons will get activated. These are called as nociceptive receptors, or you're simply speaking the pain pathway. They will go to the spinal cord. You know better than me that they will reach onto the anterior horn, posterior horn rather, then they go to the anterolateral column and ascend into the anterolateral column. Then they will reach the brain. So if we see onto the sagittal section of the brain, okay, let me draw it again. So that will reach onto the sagittal section. If we see the sagittal section, so there is pituitary, there is pons, and then there is medulla. So I'll realign it. It will go in this way and it will ascends up, reaches the thalamus. From thalamus, it will go to what is called as pituitary. Sorry, rather hypothalamus. From hypothalamus, what is being generated is called as CRH or corticotropin releasing hormone. That acts on the anterior pituitary, causes release of ACTH. You guys know better than me that this ACTH will go on to the adrenal and causes secretion of the most important marker, that is cortisol. Similarly, neurons will also activate the posterior hypothalamus, which is the sympathetic seat, and causes secretion or outflow, that is the sympathetic part of the system. This will again act upon the adrenal medulla and causes release of one most important catecholamines. This catecholamines goes on to beta cells of, or rather not the beta cells but the pancreas, and acts upon alpha cells via beta 3 receptors and causes release of glucagon. This glucagon, when it is released, it inhibits insulin production. So insulin production is inhibited. So the insulin production is inhibited and glucagon is rising. These three major hormones or neuroendocrine functions are called as together as counter hormones. Do you understand how cortisol, glucagon, and catecholamines are getting produced? Great, got it. Okay, since you are three of them, I can directly talk to three of you. Apart from this, what happens is in a small secretion, there is actually almost all hormones of anterior pituitaries are excited. So even prolactin is increased, your growth hormone is also increased. This is in addition that happens. So there are these hormones as well, but they are not actually counter-regulatory hormones. The counter-regulatory hormones are big three: the CCG, cortisol, catecholamines, and glucagon. Got it? Sure. So if you get it, you will now understand this diagram of your belly. This I have taken from I think 28th edition only. The similar diagram is in 27th edition and similar diagram is in Sebastian also. So now let us understand this. Since there is an injury, the afferent nociceptive pathway is activated. This pathway will activate hypothalamus, CRF going into pituitary, releasing ACTH and GH. You know now how. It acts upon adrenal and causes release of cortisol. Sympathetic nerves directly will go and causes release of adrenaline. Similarly, as these nerves and adrenaline, these are sympathetic nerves only, they will act via adrenaline only, will go to pancreas, beta 3 receptors and causes release of glucagon. At the same time, there will be concurrent decrease in release of insulin. In the local factors we have read, there is activation of innate immune system and interleukin 1, TNF alpha, interleukin 6 and interleukin 8 is also increased. If you want to ask me what does 8 do, 8 was simple, it is eat and 8. So I used to remember it by eat and 8 like. So what does interleukin 8 do? Sorry, 8 activates neutrophils for easy phagocytosis. Do you guys understand that this is one of the most important diagram in the first chapter and we expect a lot of questions that can come from this. Shreyas, any question from your side? But it was understand very good. If you have any question, let me know. Okay. If you Sir, hi. You keep typing your question. No worries. We'll move on to the question that was asked based on this. So what was asked is, can you repeat the last statement? Okay. So interleukin 8, I think. So interleukin 8, how does 8 act? So what does interleukin 8 do is, interleukin 8 activates neutrophils to have increased phagocytosis. How do I remember it? Eat and 8, meet and mate. This was an old saying that used to be told by one of my favorite teachers. So this is how we used to remember that when there is a eat or 8, then it will eat. Fine. Is this was this you were asking? Okay, great. So next, the questions that were asked on this particular aspect was which of the following is not a damp? So we now know that S100 protein, heat shock protein, high mobility group protein, all three of them are protein, are damps. What are not is fragments of amino acids. Amino acid fragments do not exist in a nature and a death setting. Which of them is not a counter-regulatory hormone? Now, glucagon is glucocorticoid, yes. Adrenaline, yes. Growth hormone is not. I think you guys got it now. So, since you know this diagram now, you can answer the last question also. That what happens to this blue box? All of these are getting down. So you know why is insulin getting down. But why is testosterone getting down? Because of cortisol directly inhibits testosterone release from certain cells. But why is T3 going down? Actually, what happens is TSH rises. There is increased production of T4 and T3, but the peripheral conversion is blocked. Why? Because the body doesn't want that your entire body is functioning more. What does thyroid hormone does? It increases basal metabolic rate. At the time of stress, when, for example, your gut is injured, we don't want your skeletal muscles to work more. They will keep, or they will rather do loss of energy. We want to conserve energy. And remember what happened in F phase was there to conserve energy. So body doesn't want that your basal metabolic rate rises, your entire body functions. Only those part of body which are included in repair should function. So that's why teeth peripheral conversion is being stopped. and that is why T3, is the active part, is going down. Do you guys get it? Great. So if we see one, if one goes through injury, there is ebb and flow. But is that happens in everyone with same magnitude? The actual maybe it rises in flow phase to increase BMR. No, it doesn't rise in flow phase to increase BMR because actually you don't want to increase BMR. So TSS level will not change. Yes, TSS level does not change, but there are multiple studies that has now coming up saying all the hormones of anterior pituitary rises. Even if the problem is why TSH rises is because of negative feedback loop. So T3 is going down, so negative feedback inhibition for TSH is not there, so TSH rises. But can it be because of increase corticotropin releasing or because of releasing activating factors from hypothalamus? It is not clear yet. So that's why books have not made it very clear whether TSH is rising or not. What is exactly clear is T3 is not rising. T3 levels are decreasing. You get this now? Okay, great. Sir, F के बाद flow में comes which rises, BMR rises. Yes, we'll talk to that why BMR is rising. It is not actually because of T3. We'll come to that in a while. Don't worry about it. ठीक है? Okay. So well, let's come to the next part of the topic that does everyone go through same ebb and flow phase with same magnitude? Actually, everyone goes through ebb and flow phase, but not with same magnitude. What happens is it is simple. Why this question? I tell you, one thing that was meant to ask from this question is whether metabolic response is all or none or graded. Now in life there are few things all or none. In few things you are graded. So you can be happy, very happy, sad, very sad, but you are married or unmarried. So there is something which is all or none, or you are graded in something. So this is how we act, and all those which are graded is to be countered with multimodal mechanisms. All which is all and none can be countered with one. This is the reason why we think of कि यार ये all. So what do we see? If there is injury, now we know there will be release of dams. Now these dams will activate cellular and there will be activation of nerves. Now more injury, more dams, more cellular damage, number of nerves that are being excited is high. Single nerve will be excited all and none, but number of nerves that are excited will become more. So the signal can continue for long signal, long release of cortisol, long release of adrenaline, and hence, as injury increases, hormones and dams both are increasing. That is why magnitude of response is directly proportional to injury. So this is one thing you guys need to remember. And if we see in the Bailey's picture, we see that this is the resting metabolic rate. Yeah, it is a vicious cycle. So in minor trauma, it rises till 115 maybe, but in major trauma, it goes till 130. So as the amount of trauma is increasing, the response is also increasing. Similarly, is with nitrogen exhaustion actually correlates with the protein destruction that I'm going to teach you in a while. So same thing happens with major and minor trauma in this particular regard. So when we asked you this question that a person has underwent laparoscopic splenectomy, that is elective, versus one has underwent emergency splenectomy. So the amount of injury in laparoscopic surgery is very less as compared to emergency surgery, which is very high. So the response to injury will also be high. So the rising temperature, rising heart rate in B will also be higher than that of. You get it now? So this is from Bailey 28. Let us go to the next level then. Once you understand that there is a response, I have told you in the starting that body follows what is called as balance. So if there is something which is rising and causing inflammatory and destructive systems, there is something which is called as counter regulatory system that starts. So at this local level we know that there were dams. To counteract these dams there are lipoxins, progestin. These are what is called as SPM, protective mediators that happens at local factors that are trying to inhibit dams. At systemic level we know we have interleukin 1, TNF alpha 6, 8. Now so there is what is called as interleukin 1 receptor antagonist or TNF alpha soluble receptors. So what do they do is they counteract these activating systems. That's why they are called as counter anti-inflammatory system that is called as CAS. Counter anti-inflammatory system is the term is not given in your books, but this is what is the basis that forms the basis of counter anti-inflammatory response syndrome or CARS. So you need to understand that there is a activating factor, there is a counter activating factor. So what happens is if the counter activating factors are high, the body will have an anti-inflammatory response, whereas if the counter or activating factors are high, they will have more of inflammatory response. So if we see this balance, we now know that the balance is not certain. Person can have a more of counter activating system. There will be some person who will have more of agonistic activity or inflammatory system, and this is determined by genetic variability. So this is something which we don't control. If we see this and then we understand this question, and with the help of this question let us try to understand what is CARS, that is counter anti-inflammatory response syndrome. We know that the patient has perforation peritonitis and he presented to emergency, but he had the most important thing, normal DLC. It means that he does not generated an inflammatory system, rather he has more powerful anti-inflammatory system. Okay, now what does this anti-inflammatory system does? For example, let us consider if we have a patient who has more of anti-inflammatory response. If this anti-inflammatory response persists, what will happen? The patient will ultimately get immunocompromised. Once he is immunocompromised, it will lead to secondary sepsis and that will lead to late deaths. When the inflammatory system was high, the patient can die. But if the anti-inflammatory system is high, still patient can die. What is the problem is persistence. If an inflammatory system is persisting, it is causing more havoc to the body. If anti-inflammatory system is persisting, it is also causing more havoc to the body. That is what life is also all about. You have phases of happiness and sadness, but if anything is persisting, is not good for you. Persistent happiness can turn into egos, manias, things. Persistent sadness can lead to depression, lot many worse things which we don't usually speak about. And we know that staying within the zone is something which is life all about. And that is what we take from these lectures as well. You guys get it? Great. So once you understand this, that the persistent anti-inflammatory response syndrome can also cause secondary sepsis and late death. This is also called as what is called as PIC syndrome. That is persistent inflammation, immunosuppression, catabolism syndrome. Simply called as chronic critical illness syndrome. So, if we see this patient, he was managed with emergency resection anastomosis, but he has a prolonged stay. Maybe any reason. Whatever the reason was, the CARS get persistent. The CARS and Rs, inflammatory system and counter-inflammatory system, both will get persistent if there is an injury because both arise from injury. So if there was some amount of injury, the CARS was persistent, but the patient was discharged. And now he come back in severe sepsis. But the per abdomen finding is normal. It means he doesn't have a leak. He is not failing and the count of surgery. Rather, he is failing systemically and he has now developed secondary sepsis. What is this syndrome called as? PIIC syndrome. That is what is being asked. So whether he had second perforation? No. A delayed neutrophilic response? No, there is nothing like delayed neutrophilic response. There is nothing like sterile sepsis or perforation. These both are dummy options. The only two options which actually meant were second perforation and PIIC syndrome. Do you guys get this? Because it is very difficult to understand, I understand, but yeah, if you okay, great. Rest of you, I think only Amrit is there. Shreyas is also there. Yeah, so great. So if both of you understood